Hi, everybody. Today we're going to talk about de-escalation. This is our agenda for today. We are going to go over the algorithm because we've started with that on every one of these talks. And we're going to talk about some recognition of agitation causes and then go over the specific de-escalation techniques. So let's go to our algorithm. Remember that this is all going to start with universal assessment of agitation. That's our bar scale. 4 is normal, that's our quiet cooperative patient. 5 is mild agitation, 6 is moderate agitation, and 7 is severe agitation. That's your violent patient potentially requiring physical restraints. We're asking everybody to think about a safe check. Think about your own personal safety and the safety of your patient. A is for awareness. Awareness of self, do that self-check and check in with yourself about what might influence the way that you act, as well as think about your team and the patient and what their past trauma might be contributing to what you see. F is for friends. We talked about assigned roles for everybody and who you can call on for help. Don't let anybody struggle alone. E is for environment. Look around at your physical space and what does that contribute to what's going on right now and how can we maybe change that? Okay, let's go on to some recognition of agitation and the causes. So how do you recognize agitation? What do we see or hear? We need to review some signs of escalation and agitation if we're supposed to recognize it early. You may see someone's gaze darting around, or sometimes there's an ominous glare. Some people may start to pace. Their breathing may increase. Any fidgeting or repetitive movements may be signs of restlessness and early agitation. We've all heard overt hostility in our department. Sometimes that's in combination with intimidating postures or gestures. That's your clenched jaw, fists, or fighting stance. And that's one leg that's pushed back a little bit to brace to throw a punch or to receive a punch. That's never a good sign. Some people can also be labile or explosive, and that's something we all need to be conscious and alert for. These are signs that are important to recognize and act on early. We all know that prevention is better, way better than mitigating an act of violence. Let's do a quick refresher. Can anybody name a medical etiology of agitation? Just throw one or two out there, either a specific one or a broad category. Just as a reminder, there are many potential causes or precipitating factors presenting with agitation. Remember to think broadly about your differential and avoid missing the real cause of agitation. Some people have a random other complaint, but what they're really here for is a behavioral crisis. Do they need to see psychiatry today? We also think of intoxication a lot, and that's because we see a fair amount of it, but don't limit yourself to these etiologies. Remember to consider other precipitating factor. That's the central part here. Now, agitation is part of an innate fight or flight response. Was your agitated patient really afraid? Did they understand what was really causing their symptoms? After all, they did come here seeking help. Did they have a lost sense of control? Were they hungry, tired? What was actually leading to the building of this frustration? In considering these factors, think about if there is anything you can say or offer to dissipate those feelings of fear, helplessness, or desperation. Just to show you an abbreviated list of possible etiologies of agitation, it's super long, and this is the abbreviated list. Don't stop at the obvious or common causes. Don't have premature closure and just assume that agitation is related to a given cause. Consider some alternative diagnoses. Okay, now that we've recognized agitation, let's talk about de-escalation. We're going to talk about some de-escalation techniques, but the approach depends on the etiology of agitation and your patient's ability to engage. What we're going to go over are considered best practices based on the consensus statement by the American Association for Emergency Psychiatry. This paper, if you haven't read it, is an easy, worthwhile read. So you should probably become familiar with it. Here are the basics. Some of these techniques you may have learned in one place or another or picked up from experience, but we're going to go over some concrete tips and tools so you can feel more confident with the next agitated patient you encounter. The framework for de-escalation includes 4 basic elements. That's here. The first is verbal engagement. Introduce yourself and try to engage your patient. Seems obvious, right? The next is listen. I mean, really listen. Practice empathetic listening is really important in getting to the root cause of agitation. This helps gain insight into what's really going on and what the triggers are so that you can think of how to problem solve together. Comfort measures. Whether that's offering to call a family member and give an update, or the classic turkey sandwich or warm blanket, offering comfort measures can go a long way. Last is medication. There's definitely a role for medication sometimes. Not always, but sometimes. Medication can provide a means of diffusing a situation when needed. And the choice of medication is specific to the particular scenario. Okay, here are some de-escalation tips, which all of us should really be familiar with and really try to incorporate into everyday practice. The first one is respect personal space. Now that's the 6 foot or 2 arms length distance. That's important for your own personal safety, as well as important to your patient. We don't want anyone to feel like we're invading their comfort zone without permission. It's uncomfortable and can be perceived as threatening. Next one is stay calm. It's best to keep the tone low and quiet. Keep things calm and controlled as much as possible. Don't fall into that trap of allowing your escalating patient to escalate you. We've all seen this happen. The next is verbal contact. Introduce yourself, identify your role, provide reassurance when possible, and try to have only one person engaging that patient at a time. This avoids confusion. Too many people trying to talk at once can be intimidating and escalating. We're at greatest risk of this in our trauma room where there's a lot going on at once and a lot of people around. Try to slow things down a bit and have one person take the lead. Next is be concise. Most people, when they're agitated, actually shift to using a different part of their brain. And that means they're not going to follow you if you give them long and lengthy explanations. Keep things short and simple. Allow for silence. They may need that time for processing. You're likely going to have to repeat the same message more than once, and that's normal. Identify wants and feelings. Now, this may seem silly or obvious, but de-escalation can be detective work. Like so much of what we do in the emergency department, we need to look for clues when we're looking for the real cause of agitation, and it's not always obvious. Think back to awareness. Some of what you're seeing at the bedside may be reflective of this individual patient's prior lived trauma. This ties into listening, active listening. Active listening will help you, and repeating back what you're hearing can aid in clarifying that you're getting things right. I can't stress this next one enough. This agree or agree to disagree. Agree when you can. Agree even on principle if you can. Waiting is tough. People in uniform can be intimidating. Not knowing what's going on can be scary. Usually there's something you can find to agree with. Or maybe there really isn't, and you have to agree to disagree. But don't be confrontational about it. Pivot to something you can work together on. It's important to establish those basic rules and set clear limits. Timing and the approach to this can be critical. I always try to tie this into something positive. I'm here and I really want to help you. I just can't have you yelling in my hallway though. Or at all costs, don't threaten your patients. That never helps. Security might be necessary, but try a different approach. I hear you loud and clear that you're upset, and I want to try to make things right, but security is here because they're responsible for keeping everyone safe, and you're making people scared. Can we make sure that everybody's safe together? We just want to be safe. Next is choices. Choices are empowering. Whenever you can, provide patients with options. That's always a good thing. Even if they're basic things, allow them to choose when they can. Can I bring you this or that? Do you want a pill or shot? The last step is debrief. This is a tip that we don't use nearly enough. Before walking away, make sure that you summarize what happened and just highlight what the plan is. Highlight for the patient and for your staff. You may want to highlight clear steps in the plan. And if you notice that something helped or didn't seem to work, make sure to share that with your colleagues. You may be back to this bedside, so having a clear plan and a mental checklist of what was effective can come in handy. Let's move on to a case. All right, so it's 2 a.m. and you're in our crowded ED adult waiting room. There are 45 patients in the waiting room and wait times are up to 8 hours. There are only 2 triage nurses overnight, and you have a 40-year-old man who's pacing in the waiting room. He asked 5 minutes ago how much longer the wait was. He's one of many patients who have entered the triage rooms asking the same. Public safety just asked him to keep his mask on. He clenches his fist and states, "I don't have blinking COVID and I'm vaccinated." He throws the mask that you just gave him on the floor. The officer voices understanding and states that it's hospital policy for all to be masked. "What kind of emergency room is this? I've been waiting 4 hours and I'm in pain and I might be dying." His triage note says nausea, vomiting, and diarrhea and chest pain. He did have an EKG, which had no STEMI per MD review earlier. So what do you think? We've seen patients like this. What's his bar score? He's definitely not a 4, but we can't really say if he's a 5, 6, or 7 because we haven't tried to engage him and seen his response. I want to check in with that safe check. Remember, S is safety. Well, this gentleman is not on a section and it doesn't seem like it's indicated, but we still need to try to engage him. Does he seem logical? Does he have capacity? If he does, he can choose to leave and that's okay, but we want to give him care if he's willing to stay and follow those basic rules and limits. All right, A is awareness. Do a self-check. I got anxiety just reading 2 a.m. with 45 patients in the adult waiting room. I'm sure some of you did too. Check your surroundings and think of your team and your other patients. F is for friends. Do you need support? Maybe not right now, but who would you call and what would your threshold be for getting others involved? E is environment. Do you need to move this patient? If he's not redirectable, he has the potential to escalate others in that crowded waiting room or actually cause harm. The best thing may be to remove him from that physical space, whether to the trauma room to de-escalate him or to a designated bay. I wouldn't put this agitated patient in a hallway somewhere. That's just shifting the problem. So let's think of our de-escalation options. All right, definitely respect space. This is an agitated patient, so don't get too close. Remember to keep your voice low and calm. Keep dialogue between one person and the patient. In this case, should that be the public safety officer, or would he engage better with one of the nurses who can offer him more comfort measures? Keep it short and simple. Do you know what he's feeling? Can you empathize? Have you ever had to wait a really long time for something? Can you find a way to agree? I know waiting can be hard. Believe it or not, there's a lot of people waiting here longer than you. I'm really sorry it's been such a busy night. What are some basic rules and limits that you have to set? And can you offer him choices? And what comfort measures can you offer in the waiting room? I hear you're in pain. Can I get you a warm or cold pack while I check the computer to see and give you an update? Are you still nauseous, sir? Do you think you can keep down a pill if I get you one for nausea? Remember to pair that with the limits that you have to set. I want to give you an update, but I really need you to put a mask on. There are too many sick patients here, and it's not my rule, it's the hospital policy, is to keep everybody safe. Can I step away if you put your mask on? All right, let's try another case.
Hi, I was walking by your room and I noticed you looked uncomfortable. How can I help you? How can you help me? You can get somebody in here. I've been waiting here 45
find out
minutes.
who your primary provider is. Why don't you have a seat and wait?
I don't want to sit down. Just go. Yeah, go find them. Go. Oh, maybe better yet, tell them I'm leaving. Tell them I've been waiting long enough.
There are
I am
rules
out of here.
against leaving the emergency department without talking with them, so I can find out where they
You
are
tell
right
them
now.
I'm leaving.
Don't
then.
yell at me.
Don't
Why
tell me
don't
not
you
to
have
yell.
a
I'm
seat?
waiting here 45
If
minutes.
you don't have a seat, I'm going to need to call security.
Call security.
Please have a
I won't
seat
be here when you
now.
get back. Get out of here. Get out of here. Get out of here. I don't.
Oh my. Some of you might recognize this case and may have thought of what you would do differently. But what have you noticed? Think back to those de-escalation tips we just went over. I always like to focus on positives first. Now, she did maintain a good distance from the patient. She didn't invade his space. Her standing position and hand placement was good, and her location in the room was appropriate. She had a clear exit, which unfortunately she had to use. She also tried to keep things concise, and her words when she came in anyway did offer help. There's a lot of room here, though, for improvement. She actually never introduced herself. Who is she? And when she engaged, while her words included, "How can I help you?" she invited the patient to express what his wants and feelings were, but she never really validated anything. And that can be really important. Remember, agree when you can. Waiting sucks. I can agree with that. Maybe try, "It's frustrating to wait, and I know it's been super busy. I'm here now though, and I'm willing to help. How can I best help you?" Listening. That's another area you may have noticed. She tended to cut him off and interrupt his speech a lot. And that's pretty much an example of what not to do. We have all been guilty of this at one time or another. It's hard to sometimes not interrupt someone, particularly if they're really chatty and you feel the constant pressure of time. The investment of time and patience is usually worthwhile, though. If you have to interrupt someone, you may want to restate what you're hearing to make sure that you get things right. And that'll also show your patient that you're actively listening. I hear that you're frustrated with the long wait time, and you really want to see a provider. I can assure you that someone will come by. Can you let me find someone that can address your needs? Is that the way I can best help you? I don't know if you noticed, but she didn't also stay calm. She raised her voice when he raised his voice. That's something I pick up on a lot. Maybe it's natural that we all have a tendency to do that, but we have to be conscious and actively bring it down a notch. Keep the tempo calm and voices quiet. It's always a better option. Don't be provocative either or threatening. She threatened to call security on him. That's not cool. Even if her backup plan is to call security, the threat in the heat of the moment is never helpful and will only escalate matters. There were also no choices presented to this patient. He's clearly frustrated and perhaps has a sense of loss of control, just hanging out there waiting with no clear endpoint. Offering up something as a peace offering might have helped. Provide some kind of optimism, give him choices or some viable options to pick from. I see you're pacing. Can you take a seat on the stretcher or this chair better? I hear that you've been waiting a long time. Can I offer you at least something to eat or drink? Can I bring you a ginger ale or a water? I know they sound really simple and basic, but these types of things go a really long way. These de-escalation tools are not rocket science. They're not something that I can just tell you though, and you'll just absorb. They're skills. They're things that you need to practice. Many times it's not easy and there is a learning curve. What I can tell you though, is that they're invaluable skills. You can use them at work for sure, but you can also use these same techniques at home in your everyday life. My challenge to you is to pick one or two to consistently incorporate into your everyday practice. Consciously incorporate them. Each tip in isolation doesn't always work alone, but they help you to build rapport with the person across from you and can help diffuse even the most challenging situations. Remember that we want to keep our staff and patients safe. Our goal is to provide thoughtful patient care. Utilize these de-escalation tips throughout that care delivery. Remember that bars is a continuum in two directions. 4 is ideal, and communication is key. None of us should be struggling alone. Let's work together to be proactive to address the behavioral activity level of our patients to keep everybody safe. I hope this information has been helpful. Thanks for your time and attention.